taking away any excreted waste products. And ultimately, the purpose of this lesson is to really go through and talk about all the different basic principles that are involved in hemodynamics. We're going to talk about, your basic anatomy of the heart and how the blood flows through the entire system. We're going to talk about the different components that we look at and what makes up our hemodynamics, as well as we're going to talk about some of the monitoring techniques that we use in order to have an idea of what a patient's hemodynamics are. And finally, we're going to talk about the different ways in which we can optimize a patient's hemodynamics in order to really maximize the blood flow throughout their body. All right, and with all that said, let's go ahead and jump right into our first section. And in this section, we're going to talk about the basic anatomy of the heart and the vascular system. The purpose of this, because I know all of you have had this in nursing school, you all have an understanding of the heart and how blood flows, but this is just mainly going to be a review just to make sure that we're all speaking the same language. So to start off, I just want to go through and label a few of the key parts that are really going to be important as we talk about things here. So the first is going to be our right atrium. Then down here we have our right ventricle. Then kind of a little hidden up over here we have our left atrium. And then finally down here we have our left ventricle. And as we know, these are our four major chambers of the heart. Our atrium is what pumps and feeds blood into the ventricle, and then the ventricle is what pumps into the vasculature and moves it to the various parts of the body, depending which side of the heart we're talking about. And as we all know, blood will go from our right atrium to our right ventricle. From our right ventricle, it'll go to our lungs. From there, it returns back to our left atrium, which then feeds into our left ventricle. And finally, the left ventricle is the one that pumps the blood throughout the rest of the body. And one important thing to be aware of is, as we know, as the blood passes to and from one chamber of the heart, it passes through different heart valves. And these various heart valves are going to be really important for you to know, because if somebody has certain insufficiencies or problems with these valves, it's going to cause problems with the way that the blood is flowing and will ultimately impact our hemodynamics. So as we go through and talk about our valves, as we talked about, the blood starts in the right atrium. And the first valve that we are going to pass through is this valve here, and this is going to be our tricuspid. From there, the blood is going to be in the right ventricle, and when the right ventricle contracts, it's going to pump the blood out through this valve here, which is going to be our pulmonic. From there, the blood will make its trip and come back into the left atrium, at which point the blood will then pass from the left atrium to the left ventricle through what we call the mitral valve. Sometimes you may also hear this referred to as the bicuspid valve. And then finally, once the blood is in the left ventricle, when it contracts, it will enter the aorta through the aortic valve. So again, if we think about the path the blood is going through, we're going to go from the right atrium through the tricuspid valve into the right ventricle. From the right ventricle through the pulmonic valve, it's going to pass along, end up into the left atrium, at which point we're going to pass through the mitral valve into the left ventricle, and finally out the aortic valve. And I know that the location of these particular valves can be confusing for some nurses, especially starting out. So it's really important that you just remember that series that they go through: tricuspid, pulmonic, mitral, aortic. TPMA, tricuspid, pulmonic, mitral, aortic. Now I want to talk about a few of the different vessels that play an important role in this flow of blood. The first is going to be the two largest veins that are responsible for returning the blood flow to the heart. Those you're going to find over on the left here. We have up at the top our superior vena cava, which is going to be returning blood from the head and the upper extremities. And then we have our inferior vena cava, which is essentially returning all of the blood from the rest of the body. There is one last little section here. I'm going to put it right about here. And this is our coronary sinus. And finally, this is the last bit of blood that is being returned to the right atrium from all of the coronary vessels. And so after that, the blood is going to be ejected from the right side of the heart, from the right ventricle, out through the pulmonic valve, and it's going to enter into the pulmonary artery. Now, an important distinction here is we are calling this an artery because the blood is going away from the heart, but this is still deoxygenated blood because it is on its way to the lungs, and this is why we have it drawn blue in this section here. From here, the blood is going to go to the lungs, it's going to pick up oxygen, deliver carbon dioxide, and there it's going to return back through a series of vessels over here we call the pulmonary veins. And again, these are veins because they are returning blood to the heart, but at this point they are oxygenated, so this is why we have it red here. And also note that we do have two sets of these pulmonary arteries and pulmonary veins. So we have ones that are going to and from the patient's left lung here, and then we have ones that are going to and from the patient's right lung over here. And so now the blood is in the left side of the heart. It will be ejected from the left ventricle via the aortic valve, and from there it's going to pass into the aorta. And this is where the blood is going to begin its travel to all the different parts of the body. And so just as one big review of the whole flow of blood, we have the blood coming from the superior vena cava, inferior vena cava, and the coronary sinus, which are emptying into the right atrium. It's then going to pass from the right atrium through the tricuspid valve into the right ventricle. From there, it's going to be ejected out the pulmonic valve into the pulmonary arteries, which are going to travel to the left and right lungs. From there, the oxygenated blood at this point is going to return via the left and right pulmonary veins into the left atrium. The blood is going to pass through the mitral valve into the left ventricle. And then finally, the left ventricle is going to eject that blood through the aortic valve into the aorta and throughout the rest of the body. Alright, so let's look at things a little bit differently and have a little bit different picture of the hemodynamics and blood flow through the body. So here I have things set up a little bit different. We have the right side of our heart over here, so obviously our right atrium and our right ventricle. And then over on the other side, we have the left side of our heart. So again, we're going to have our left atrium and our left ventricle. And again, just to map out the flow of blood, so we have our superior vena cava, which is feeding in here. Also our inferior vena cava, which is feeding up here. And then lastly, our coronary sinus, which is also feeding into the right atrium. And all of this blood is going to move across our tricuspid valve into our right ventricle. From there, the right ventricle is going to contract. It's going to eject our blood out through the pulmonic valve into the pulmonary artery. And from there, it's going to travel to the left and right lungs. This is now where, obviously, our blood is going to pick up oxygen and travel back and enter into the left atrium. From there, we're going to cross the mitral valve into the left ventricle. And then the left ventricle is going to contract and push the blood out the aortic valve and into the aorta. Now, once the blood is in the aorta, there's really three main ways that it can go. The first of these is to go up to our brain and upper extremities. It can also go and travel down and around to the rest of the body. And the last route that the blood can take is in diastole. The blood will actually travel back and fill into our coronary arteries in order to perfuse our heart. So then again, if we continue to follow the path of blood, from the aorta, we're going to branch off into our arteries, and then we're going to branch off into our arterioles, and those are going to turn into our capillaries and capillary beds at the end of the tissues. And then once they come out from the capillary beds, we're going to come out into our venules, which will turn into our veins, which will then work their way back either through the inferior vena cava, or if we're coming from the brain or the upper extremities, we're going to come back in through our superior vena cava. And this really gives a conceptual map or picture of the flow of blood, which ultimately is our hemodynamics. And it is important that you understand this flow, where the blood is going at different points, Like I said, know the valves that you're going through, know what vessels you're going into, and this will all play a role in determining our patient's hemodynamics. And later, when we get to talking about optimizing those hemodynamics, if you have a good understanding of this flow, then things will be much easier for you. So at this point, this concludes this lesson on hemodynamics and covering the anatomy of the heart and the vasculature that plays a role. In our next lesson, we will talk about the actual delivery of oxygen, which is the whole goal of hemodynamics. Alright everybody, welcome back to our next lesson on hemodynamics. In this lesson, we are going to talk about the delivery of oxygen, which is ultimately the end goal of our hemodynamics. The goal is to deliver oxygen as well as nutrients to perfuse our end tissues, and also while they're taking away any waste products that are a result of metabolism. But ultimately, the most important thing is getting the oxygen to our tissues. And in this lesson, we're going to talk about and we're going to cover a few different equations that are used in understanding our hemodynamics. I do want to preface this and say the point of this is not to have these as something that you guys need to memorize, but really just to break it down and help you understand the components that all play a factor in the hemodynamics and ultimately the delivery of oxygen. So the first equation we're going to look at is just that, our delivery of oxygen. So this is going to be our DO2. And the equation for our DO2 consists simply of our cardiac output times the concentration of oxygen in the arteries times a factor of 10. And the 10 is really just there to get our units of cardiac output and the concentration of oxygen all on the same page. Now, you may look at this equation, it may seem a little scary or overwhelming in trying to understand how does this play into hemodynamics. And like I said, the goal is to understand the components. Our end goal is to deliver oxygen, and in this case, we can see that the components that make up our delivery of oxygen are our cardiac output, which is going to be how much blood we're circulating through our body, and their concentration of arterial oxygen, which is basically how concentrated is the oxygen in the blood that we're beating. So the concept is pretty simple, but I do want to break this down a little bit further in order to better understand what is happening. So the first one I want to talk about is our concentration of arterial oxygen. So that's going to be our CaO2. And big surprise, guess what? There is an equation that we can use to determine what this concentration is. And this is going to consist of our hemoglobin times 1.39 times our arterial oxygen saturation. Then we're going to add our partial pressure of arterial oxygen and multiply that by 0.003. Now you're probably looking back at the DO2 equation, and initially we were thinking that was kind of a complicated equation to look at, and now you're looking at this and you're like, what the heck is going on here? So again, my point of this isn't, I don't want you to memorize this equation. There may come a point later on in your nursing career as you become more advanced, more trained, that this may play a role in some of your practice. But for the most part, the reason I'm explaining this here is I want you to understand a couple key concepts that I want to take away from this. The first of these is that in order to determine how concentrated our oxygen is in our blood, that there's three factors that go into this. We have our hemoglobin, we have our oxygen saturation, and we have the partial pressure of oxygen, which is going to be our PaO2 off of our ABG. And if you take a look and see where these components play into this equation, you can see that our PaO2 actually makes up a pretty insignificant portion of our concentration of oxygen, because we're going to multiply that by 0.003. Whereas our hemoglobin and our oxygen saturation, we're multiplying by 1.39, so obviously we're going to end up with a larger number. So to really drive this point home, I do want to give you some values so we can plug it into the equation here and really see the point that I'm trying to make. So let's say we have a hemoglobin of 7. We would take that and multiply that by 1.39. Then we would multiply by, let's say we have an oxygen saturation of 0.95. If we do the math on this, this gives us a grand total of roughly 9.24. Now, if we move over to the other side of the equation, let's say we have a partial pressure of oxygen off our ABG that is 400.
I Lidl finder du altid sommerens weekender. Fra torsdag får du for eksempel 1 kilo lammefjords aspargeskartofler.
We'll multiply that by 0.003, and that'll give us 1.2. So here you can see, even with a very high partial pressure of oxygen, it's still only composing a tiny part of our total amount of concentrated oxygen in our blood. And really, the important takeaway from this is the two biggest factors in determining how much oxygen we're going to have in our blood is going to be our hemoglobin and our oxygen saturation. Well, hopefully that makes a little bit of sense for you guys in understanding how we determine how much oxygen is going to be in our blood. If we go back and look at our delivery of oxygen equation, the other factor that is used in determining how much oxygen we're delivering is going to be our cardiac output. And so our cardiac output, if we go ahead and bring that down here, we do have another equation for this, and this is going to be cardiac output is equal to our heart rate times our stroke volume. And if we take a look at these components, essentially what this is saying is, if we take how much blood is being ejected with each beat, which is our stroke volume, and multiply that by how many beats per minute, which is our heart rate, it's going to tell us what our cardiac output is in liters per minute. So just to give you some normals on some of these numbers, our stroke volume is normally going to be 60 to 120 milliliters per beat. We should know our heart rate is normally 60 to 100 beats per minute. And our cardiac output is going to be 4 to 8 liters per minute. It is important to note that cardiac output doesn't take into consideration the size of your patient. So if you have a small lady with 4 liters of output, that's going to be a big difference when we're comparing that to 4 liters of output in, let's say, a 350-pound man. So this is where there's another thing that comes into play that we call cardiac index. And essentially, cardiac index is just going to take your cardiac output and your body surface area and determine how that output relates to the size of the person. And this way, no matter what the size the person is, we can talk about the same numbers and have an idea of how sufficient or insufficient that cardiac output is going to be for that patient. So for our cardiac index, our normal numbers are going to be 2.5 to 4, and this is actually in liters per minute per meter squared. Now finally, from all this, we can break things down one more time, and that's if we take a look at our stroke volume. There are 3 factors that go into determining what our stroke volume is going to be, and that is going to be our preload, our contractility, and our afterload. Now, in a little bit, we will get to talking about these different components and what they mean and how they impact our stroke volume and ultimately our cardiac output. But for now, I just want you to understand how, if we take a look with our hemodynamics, our ultimate goal is about delivering oxygen. And if we take that calculation and break it down, we can see how our cardiac output is composed, as well as how the concentration of oxygen in that blood is composed, and to give you a good understanding of those components, why they're important, and ultimately how they affect our hemodynamics. And that's going to conclude this lesson on hemodynamics, talking about the delivery of oxygen. In our next lesson, we are going to talk about our cardiac output and all the different factors that play a role in determining what that cardiac output is.
Well met.
All right, welcome back to our next lesson on hemodynamics. In this lesson, we're going to be talking about our cardiac output, as well as the different factors that go into determining what is our cardiac output. And so just for a little refresher, let's go ahead and throw up our cardiac output equation. So again, we have our cardiac output is equal to our heart rate times our stroke volume. And again, let's just hit on our normals again. Stroke volume, normal is going to be 60 to 120. Heart rate is going to be 60 to 100. Cardiac output is going to be 4 to 8. Unless you're looking at our cardiac index, then you're going to be 2.5 to 4. Now, one really important thing to know about our heart rate and our stroke volume in this equation is that they work together almost in a seesaw-like manner. So let's say we have our heart rate over here and our stroke volume over here. Our heart rate is going to compensate for changes in our stroke volume. So if our stroke volume is high, we're going to have a lower heart rate as a result. And by the same token, if our stroke volume were to decrease, then we would see our heart rate increase in an attempt to compensate for that decreased stroke volume. So without much ado, let's go ahead and move on to the first component of our cardiac output, which is going to be our heart rate. And like we just talked about with the heart rate, the big important thing with the heart rate is its goal or its job is to compensate. So it's going to compensate for changes in our stroke volume. So let's say, for example, we have decreased stroke volume. What this is going to lead to is an increase in our heart rate, which oftentimes we refer to as tachycardia. So again, that heart rate is trying to speed up in order to give us more beats per minute because our stroke volume is now a smaller volume. Some of the things that are going to contribute to tachycardia are going to be hypovolemia. And this could be as a result of dehydration, fluid loss, or even blood loss. Another thing would be low blood pressure. Also, if we think about our sympathetic nervous system, so this is going to be our fight or flight. So if you think about in those situations, the body releases the catecholamines, which are going to increase your heart rate. And then also other things like fever, or even something as simple as, and I know I don't do enough of this, exercise. These are all going to be things that are going to increase our heart rate. One important thing to know when we're talking about tachycardia as a form of compensation is there are limits to how much we can compensate for decreased stroke volume by increasing our heart rate. So if we have a normal, healthy person, typically a heart rate that's greater than 180 beats per minute, if you have a rate that is faster than that, you're not going to have enough time to fill the ventricle between each beat, and as a result, If you continue to increase your heart rate, you're not going to see an increase in your cardiac output as a result, and therefore it's no longer going to be able to compensate. Now, this is in a healthy heart. So if you have someone that has either a deconditioned heart or a diseased heart, oftentimes anything that's greater than 120 beats per minute is no longer going to be able to compensate. So important things to keep in mind as your patients are becoming increasingly tachycardic, that at some point, and depending on the health of their heart, it's no longer going to be doing them any good, and in fact may be hurting them. So now on the flip side of tachycardia, if we are in a situation where we have an increased stroke volume, this is going to lead to a decreased heart rate, and this is what we refer to as bradycardia. Now, one great example of this we often see in our athletes. And if you think about with these patients, they have very strong cardiac muscle, so they have a great stroke volume, and as a result, their heart rate is going to compensate and lower. And so a lot of times you'll see these patients with heart rates in the 40s and 50s, and they're totally fine. Now, the last important thing to talk about when we're talking about our heart rate are things that can lead to alterations. So either alterations in the regularity or alterations in the physical beating of the heart. So for example, if we talk about patients that have arrhythmias, so if they are in a fib, a flutter, let's say they're in a junctional rhythm or even an idioventricular rhythm, this is going to have an effect on both our heart rate and the examples of either slow rates with junctional or idioventricular rates, or fast rates such as a fib or a flutter. But these arrhythmias can also cause dysynchrony between atria and ventricle, which can also impact our cardiac output. Another thing that's going to have an impact on our heart rate is if we have different heart blocks. And this is primarily going to be our second degree and third degree blocks, but these are going to impact our heart rate and again will have an effect on our cardiac output. Also, if a patient has had an MI, this can as well have an impact on our heart rate. And then finally, if our patients are on either beta or calcium channel blockers. These medications are all going to have an impact on our patient's heart rate, as well as their ability to compensate in situations where their heart rate may need to increase in order to make up for decreased stroke volume. All right, so that covers everything with our heart rate. So let's go ahead and move on to the next component of our cardiac output, which is going to be our stroke volume. So once again, for a refresher, we'll go ahead and put our cardiac output equation. So our cardiac output is equal to our heart rate times our stroke volume. And if you remember, we talked about our stroke volume is primarily composed of three factors. And those three factors are, again, our preload, our contractility, and our afterload. And so let's go ahead and talk about these different factors. And to start off, we're going to talk about our contractility. And so to put it simply, contractility is simply the squeeze that your heart is able to do. So this is going to be the force of the contraction that the heart or the ventricle is able to beat with each time it contracts. So as an example, if we have an increased contractility, this is going to lead to an increased stroke volume. And so if we think about it, the more squeeze we have, the more blood that we're going to eject with each contraction. As a result of that, though, this is going to lead to an increase in our myocardial oxygen demand. By having that increased squeeze, it's going to take more energy, more force from the heart, and as a result, it's going to require more oxygen to do so. Things that can lead to increased contractility would be things like, again, our sympathetic nervous system. And again, like we talked about, that fight or flight system will not only increase your heart rate, but it will increase your contractility. And then also things like exercise. Now again, on the flip side of this, if we have a decrease in our contractility, that's going to lead to a decrease in our stroke volume. But as a result, we are then going to have a decrease in our myocardial oxygen demand. And some of the things that can lead to a decreased contractility would be if your patient has had an MI, if they've had cardiac surgery, things such as hypoxia, hypercapnia, hyperkalemia, or hypocalcemia are all things that can lead to decreased contractility. And then finally, metabolic acidosis can also have a negative effect on the contractility of your heart. Okay, so moving on to the next factor in our stroke volume is going to be our preload. And our preload is often referred to as our filling pressure. Essentially, the preload is the amount of blood that's in the ventricle prior to contraction. A lot of times you'll hear this referred to as how full the tank is. So essentially it's that filling pressure, how full, how much volume do we have in order to aid in contraction. Now with our preload, there are three main factors that play a role in determining what our preload is going to be. So the first of these is going to be our blood volume. So essentially, if you don't have any blood, you're not going to have any volume for your preload. Next is going to be the distribution. And this is referring to the distribution of fluid and volume in your body. Is it in your vasculature? Is it inside of the cells? Or is it in the third space? What is the availability of that volume to contribute to preload? And the last factor that we hit on just briefly when we were talking about the heart rate is going to be our atrial contraction. And really what we're asking is the atria beating in conjunction or in synchrony with our ventricle? As we know, when the atria contracts, it forces that last bit of blood into the ventricle, really filling it prior to contraction. And this atrial kick can actually account for as much as 20% of our stroke volume. So if our atria is not beating in synchrony with our ventricle, for example, in a fib or a flutter, then we're not going to get that good atrial kick and we'll have an impact on the preload. In order to really understand preload and have an idea of how it is that it impacts our stroke volume, you need to understand something called the Frank-Starling law. And the basic concept behind the Frank-Starling law is an increase in preload equal an increase in our stretch of cardiac muscle, and this equals a stronger contraction. And the best way to really kind of understand this or visualize this is if we take, let's say we imagine a rubber band here. If we take that rubber band and we stretch it out, when you let go, that rubber band is going to snap back with more force. And so again, if we stretch it out even further and we let go of that rubber band, again, it's going to snap back with even more force. And that's the basic principle behind the Frank-Starling law. As we increase that preload, it's going to stretch the ventricles more, and by stretching those ventricles more, they're actually going to be able to have a stronger, more forceful contraction in ejecting the blood. Now, there is a caveat to the Frank-Starling law in this concept of stretching and stronger contraction, and that is that there are times that you can actually overstretch the heart so that it's not able to contract as forcefully. And this is going to be when we're talking about congestive heart failure. And so it is going to be important that when we are talking about preload and the Frank-Starling law, that we do talk about a concept called compliance. And with compliance, there's two different things that we worry about with our compliance. We can either have an increase in our compliance, or we can have a decrease in our compliance. An increase in our compliance is often referred to as overstretch. And this you're going to see in patients that have CHF or a dilated cardiomyopathy. So essentially the heart has too much compliance, it's able to stretch too much, and as a result you're not able to get that forceful, strong contraction that you need. Now on the opposite end, a decrease in compliance is not going to be able to stretch or accommodate. And you might see this in patients that have had an MI, in patients who have a restrictive cardiomyopathy, and also in patients who have a stunned myocardium, and examples of this would be trauma or cardiac surgery. So again, that compliance will play a role in the heart's ability to effectively deal with the volume or the preload that it is receiving. Alright, so let's go ahead and move on to the last factor that impacts our stroke volume, and that is going to be afterload. Now, afterload can be simply summed up as resistance. So essentially, how hard does the heart have to beat in order to eject its blood? This is also something you'll commonly hear referred to as how clamped down is the patient. And just to give you a little visual representation, if we have our heart, and let's say we've got a nice big wide aorta to beat in, it's going to be a bit different than if we had one with a tighter or more restricted aorta, because essentially afterload is that resistance that the heart is having to overcome each time it's beating to try and eject its blood. Now with this as well, we are going to have 3 factors that are going to impact our afterload. The first of these is going to be the compliance of the aorta. Now the compliance of the aorta is talking about its ability to stretch with each beat. So if you have a more compliant aorta, when the heart beats, it's more easily able to stretch, as opposed to a non-compliant aorta, which is going to be a stiffer aorta, and as the heart beats each time, it's going to be beating up against a stiffer vasculature. The next factor that plays a role in our afterload is going to be just that, the vascular resistance. And that's exactly what I just drew above with the pictures there. It's the amount of resistance that that heart is meeting. How wide or how clamped down are those vessels that the heart is having to beat against? Obviously, the wider, larger vessels, the easier the heart's going to be able to beat, and the more constricted those vessels are, the tougher it is to beat against that. One thing to note with this here is if you have a patient who is hypoxic, that this can actually lead to an increase in vascular resistance. And the final factor that's going to play a role in our afterload is going to be the viscosity of the blood. So essentially, how thick or how thin is that blood? Thicker blood is going to be heavier and tougher to move, as opposed to thinner blood, which is going to be able to flow more freely. And those are the three factors that determine our resistance or our afterload. And at this point, we've covered all the different factors that go into determining our cardiac output, from our heart rate and stroke volume to breaking our stroke volume down into our preload, contractility, and afterload, as well as talking about some of the basic principles of each of those. This concludes this lesson on hemodynamics and our cardiac output component. In our next lesson, we are going to talk about how we monitor our hemodynamics. Alright everybody, welcome back to our next lesson in our series on hemodynamics. In this lesson, we are going to be talking about the different ways in which we monitor or track our patient's hemodynamics. So to start off our discussion in monitoring hemodynamics, the first thing that we're going to talk about is our non-invasive forms of monitoring. Now I know in this day and age with modern technology that we oftentimes rely on other ways to monitor our patient, but at its very core, hemodynamics has a direct effect on our body and our various body systems. Being able to assess and monitor things that are going on with your patients without the need for all the fancy technology that we have today will really make a difference in your nursing practice. And you won't always have, all the different lines and ways of monitoring your patient's hemodynamics at all times in order to be able to tell what's going on with them. And one thing I've noticed is with some physicians, especially ones that have been around and have been doing this for a while, that when they come in and see their patients or they assess their patients, obviously they're looking at all the information they have available to them, but one of the most important things that they do is lay their eyes on their patient, listen to their patient, and feel their patient. And that's really the essence of non-invasive monitoring. It's that look, listen, and feel. It's that going in there and actually looking and seeing what's going on with your patient that will really tell you all that you need to know. So later on, when we get into talking about some of the more advanced invasive forms of monitoring that we can do, sometimes the numbers that you see don't add up with the picture that your patient is presenting. So it's really important that you have a solid foundation of actually being able to go in there, look at your patient, assess them, and see what is actually going on with them, because it will tell you a heck of a lot more oftentimes than what your monitor will. So ultimately, when we're talking about hemodynamics and the flow of blood through the body, if we have some sort of compromise to that system, the end result of that is going to be decreased or lack of perfusion to the end tissues. And our ability to assess these changes that result are what make up our non-invasive monitoring of the patient's hemodynamics. Now, when we have decreased flow or decreased perfusion to various organ systems, they don't all just stop being perfused at the same time. The body has certain fail-safe mechanisms that it will put in place when it is faced with a situation where it's now having decreased blood flow, and the body will begin to shut off blood flow to certain parts of the body in a systematic approach to try and preserve perfusion for more vital organ systems. So when we start talking about decreased perfusion in the body, there are certain primary signs. Essentially, these are the first things to go. And these first things to go are going to be the skin and the gut. So in a state of decreased blood flow, the body's going to cut out the least important things first. And in this case, blood flow to our skin and even our GI tract is going to be very low on the totem pole in terms of importance of organs. So some of the signs that you're going to see with this are going to be cool, clammy skin. You could also see pale, ashen, or cyanotic skin. You're also going to notice decreased bowel sounds. Your patient could be exhibiting diarrhea or even constipation. And if they have an NG tube in place, you're going to see increased NG output. So if you think about the body is shutting down blood flow to the skin and the gut, these are the consequences, the things that you're going to be able to visually, tactilely, auditorily be able to pick up on in order to sense that your patient is having an alteration in their hemodynamics. So if we continue to go along and the body has already shut off blood flow to the skin and the gut, and we continue to have problems with our hemodynamics, our blood pressure, the body's going to start going up the totem pole in terms of importance. So our secondary signs, so think of these as the next things to go, and these are going to be their kidneys, liver, and lungs. And signs that you're going to see that the body is beginning to shut down blood flow to these organs, you're going to see an increased respiratory rate and effort. Your patient may be short of breath. You may notice a decreased either PaO2 or decreased SpO2. You'll start to notice concentrated urine. You'll have decreased urine output. And then along with that, you'll begin to see a rise in your BUN, creatinine, and potassium. And then you may also see a rise in your ALT, AST, and an increase in your clotting times. So now with these secondary signs, the body's already tried cutting off blood to the skin and gut. That wasn't enough. So now it's cutting back or turning off blood flow to a little bit more important organs, our kidney, liver, and lungs. Definitely things that play an important role in our body's functioning, but if it's for a short period of time, they are things that the body can still function despite dysfunction in these organs. And so at this point, it's saving all the limited blood flow and perfusion that the body has left for our brain and our heart. Because without those, we've got nothing. So then that obviously leads us into our final signs. And as I already mentioned, this is going to be our brain and our heart. At this point, the body has done everything it could to preserve any last bit of perfusion to these two vital organs. And if perfusion is still not enough, then these are going to be the final signs that we see. So some things in here are either going to be a decreased or altered level of consciousness. You're going to notice disorientation. You're going to notice slow reacting pupils. Your patient may have either chest pain or chest pressure. Your patient may either be tachycardic or bradycardic. And along with that, they may also have ectopy. And finally, you may also notice ST elevation. And so you can see that from this list here, a majority of the things that are on this list, you do not need any fancy monitor or invasive line or anything special in order to be able to notice these changes. And sometimes these are changes that you may notice trends before you begin to see things on the monitor. So it's a habit that I've forced myself into. Like I mentioned, I've seen physicians do this as well. But if something seems off about your patient or they're just not doing well, along with looking at your numbers and your monitor, go in there and lay eyes, touch them, feel them, have a sense of what is actually going on, because they will tell you a lot. And a few last things to include in here with this non-invasive monitoring section. Obviously, all the patients that we have in the ICU are going to be on a cardiac monitor. They're going to have pulse oximetry, and we're going to have, at the very least, a blood pressure cuff in order to keep an eye on their blood pressure. So I did want to talk about our blood pressure just a little bit to give a little better understanding of what is going on with that. And our blood pressure is simply a combination of our cardiac output and our systemic vascular resistance. And that's how our blood pressure is calculated out. The important number that we look at with our blood pressure is going to be our mean arterial pressure. And your mean arterial pressure, or MAP as it's often referred, is really the most important number, because it's your number that tells you how much perfusion you're getting. So as you know, with your blood pressure, you have a systolic and a diastolic, but your MAP is the average across that full cardiac cycle, and this will determine if you're getting enough perfusion to your vital organs. And from patient to patient, there's going to be variations in what is an appropriate MAP or how much of a MAP is needed in order to perfuse their organs. But typically, we want to keep a MAP greater than 60, and this usually will tell us that we're perfusing in tissue. Now, just to give you guys a quick equation for the mean arterial pressure, it is more complicated than this, but there is a pretty rough and pretty accurate calculation that you can do, and that's if you simply take 2 times your diastolic blood pressure plus your systolic blood pressure and divide all of that by 3. That will roughly give you your mean arterial pressure. As you know, we spend twice as much time in diastole as we do in systole, so hopefully looking at this equation, it makes sense. And the last thing that I want to talk about in here is a concept that we call our pulse pressure. And our pulse pressure is a simple equation where we just take our systolic blood pressure and we subtract our diastolic blood pressure. And the whole point of the pulse pressure is to tell us or show us how wide or how narrow of a difference is there between our systolic and diastolic pressures. This will come in later on when you're looking at determining what is going on with your patients, whether they have a very wide pulse pressure or a very narrow pulse pressure, or one that's widening or one that's narrowing. And that can tell you a little bit about what might be happening with your patient as well. All right, well, that will go ahead and conclude this lesson on hemodynamics and more specifically our non-invasive monitoring. In our next lesson, we're going to take a look at invasive monitoring. All right, and welcome back to our next lesson in our series on hemodynamics. And in this lesson, we're going to talk about everybody's favorite working in the ICU, which is our invasive monitoring. So, as we all know, invasive monitoring is very common in the ICU. Especially these days, we have very sick, very complex patients. And the various forms of invasive monitoring that we have available to us can really tell us a lot about what's going on with our patients, with their hemodynamics, how their hemodynamics are responding to the various treatments that we're putting in place, as well as how their blood flow is being impacted by other forms of treatments that we're doing for them. So there's a lot of valuable, great information that can come from the various invasive monitoring techniques that we have available to us. But at the end of the day, just remember that it all goes back to the basics. So just because certain numbers are telling you certain things on the monitor, you still need to look at your patient and see, does the patient line up with what you're seeing on the monitor? You could have great numbers on the monitor and your patient not look so hot, and there's probably something going on. On the flip side, the numbers could look awful on the monitor, but look at your patient. Is your patient fine? Are they doing okay? And if so, it might not be telling you the full story. All right, so we're gonna talk about a few different types of invasive monitoring. The first one that we're going to talk about is our CVP. So our CVP is going to be giving us a representation of our right atrial pressure, or basically the venous return to the heart, essentially our preload. And this is going to be the right heart preload. The nice thing about CVP is if you have a central line in place, you can simply use one of the lumens on your central line in order to obtain a CVP. And when you have a patient that you're monitoring their CVP up on the monitor, you're going to see a waveform that looks something like this. Now, when we talk about the normal values for CVP, it really depends on the source that you're looking at, but on average, typically you're going to be looking for numbers to be between 2 and 10 millimeters of mercury. Now, like I said, since the CVP is essentially measuring our preload, and if we think about situations in which our CVP or our preload is going to be increased, these would be things like fluid overload. So if you had too much fluid, you would have a high preload. Another situation in which you might see an increased CVP would be is if your patient is having cardiac tamponade. So in this scenario here, the tamponade is preventing the heart from being able to beat effectively, so we are going to get a backup as blood is not passing through the heart, so this will increase our CVP. And another situation in which you might see an increased CVP would be in right heart dysfunction. So similar concept with the cardiac tamponade, the right heart is not functioning appropriately, therefore it's not moving the blood across to the lungs and into the left side of the heart, therefore you're going to get a backup heading into it. Now on the flip side, some cases in which you might see decreased CVP or decreased preload would be things like dehydration, volume loss, and this can be either fluid or blood. And lastly, venodilation. And this is essentially dilation of the veins that cause pooling of the blood, not allowing it to be returned to the right atrium. All of these things are going to contribute to a decreased volume returning to the heart, therefore a decreased preload, and you will be able to measure this with a decreased CVP. Alright, so moving on and talking about the different forms of invasive monitoring, the next one that we are going to talk about is the arterial line. So the arterial line, or A-line as it's commonly referred, is essentially a catheter that is sitting inside of an artery, and typically our common spots are going to be either our radial, our femoral, sometimes you can do a brachial or even a pedal A-line, but it's going to give us a direct and, more importantly, a real-time representation of systolic and diastolic, as well as giving us a calculated mean arterial pressure. And the real beauty of the A-line is the fact that it is real-time. So this is great if you're on any sort of vasoactive medication that you need to see real time what are the effects of this medication and where is my pressure currently at. Now typically the waveform that you will see will look something similar to this. Now, not the greatest of drawings, but essentially this is going to be our systolic blood pressure right here. We're going to have our diastolic blood pressure, and then here you're going to have your dicrotic notch. And it's going to be important that you evaluate this waveform to ensure that you're getting an optimal and accurate reading. If the waveform becomes underdamped or whipped, a lot of times you'll see a peaking, a very high systolic that goes significantly above the rest of your waveform. Sometimes you also see a even lower diastolic. So when you're comparing these numbers to your manual cuff, you'll see a higher systolic and a lower diastolic. That will be one indication that you are underdamped or not accurate. You can also be overdamped or beginning to flatten, and this is then you're going to lose the nice picture of your waveform. You may lose seeing your dicrotic notch. Your systolic is going to lower. Your diastolic may come up, and again, it's not going to be an accurate number, which if you're titrating vasoactive medications, it's going to be important that you do have an accurate waveform. Now, if the waveform is accurate and you have discrepancies between your A-line and your manual cuff, first you obviously want to troubleshoot your A-line and your transducer, and all of that is fine and taken into account. Then the A-line is going to be a more accurate representation of your blood pressure because it's directly in the artery. It's giving you a direct representation of actual pressures into a waveform and numbers that we can see on our monitor, whereas opposed to the automatic blood pressure cuffs that most monitors use are actually calculated values. And I won't go into the complex nature of how they work, but know that it's not like when you listen or you auscultate with a manual blood pressure. It works in a different manner, and it's calculating out your systolic and your diastolic and your mean arterial pressure. So again, if your A-line waveform is good and those numbers differ from your manual blood pressure cuff, you want to be going off of your A-line because it is going to be the truer, more accurate number. All right, now moving on, the next form of monitoring that we're going to talk about is a system called the FlowTrack. Now this is a proprietary system that is developed by Edwards Lifescience. It does require its own transducer to be used in place of the typical ones that are often used, as well as its own monitor setup. But in my opinion, it is a pretty neat form of monitoring that we have available to us. And the nice thing about it is it simply uses A-lines and the setups that we use for A-lines minus the transducer, just like we do with any other patient. So we can actually get a lot more information and a better picture about our patient's hemodynamics simply from the arterial line, which before was only giving us our systolic, diastolic, and our mean arterial pressure. Now, the purpose of this lesson isn't to go through all the bells and whistles of what the FlowTrack can and can't do, but I do want to give you a basic understanding of some of the numbers and the information that it can give to you. So this is going to be a representation of the newer model FlowTrack. You might be familiar with the older model. It's referred to as the Vigileo. It will give you all the same numbers, just not in as newer of a user interface. But this is our screen that we have here. On the side, you've got a series of options and buttons that you can select, and this is all on a touch screen. On the FlowTrack, above and beyond just your normal pressures that you would get with an arterial line. and those are going to be and stroke volume index, obviously determine what. So the final hemodynamic decreased volume, where you see less right ventricle and come out and sit in what the in a lot of many of our patients have already. So moving on, we're going to move to the last form of invasive monitoring that we are going to talk about, and that is going to be our SWAN, or our PA, or pulmonary artery catheter. Now, the SWAN, or the PA cath, has had its ups and downs over the years when it comes to studies in terms of whether it is an effective form of monitoring our patients' hemodynamics or not. But they certainly are something that are used in a lot of environments, particularly in cardiovascular ICUs and with open heart patients. So they definitely still have their place in the practice that we can provide for our patients. And essentially what the SWAN is, or the PA catheter is it's a very long catheter that is inserted through an introducer that will go in through the vena cava. It will pass through the right atrium of the heart into the right ventricle and come out and sit into the pulmonary artery. At various points along the catheter, there are ports that enable us to either infuse medications or to get pressure readings, which can give us different pressures at different locations throughout the anatomy of the heart and the vasculature, which can give us more of a picture of the hemodynamics of our patient. So with the SWAN catheter, there's going to be 4 main values that we are able to obtain from the catheter itself. The first one is going to be our right atrial pressure, or our CVP. The next one is going to be our pulmonary artery pressure. The next one after that will be our pulmonary capillary wedge pressure. And finally, the last one will be our cardiac output and cardiac index. So for our right atrial pressure, or our CVP, again, the waveform is going to look just like we talked about with the CVP already, and the same normal values are going to apply to this as well, 2 to 10 millimeters of mercury. All right, now, so for our pulmonary artery pressure, essentially the tip of the catheter is sitting in the pulmonary artery, and at the very tip of the catheter, there is a port in order for us to be able to measure pressure. Typically on the monitor, you will see a waveform that looks something similar to this.
Trading is not for everyone, but if you are a trader, Plus 500 is the place for you. With just a few clicks, you can open an unlimited demo account and get to know your way around. Open your desired position in seconds and start trading CFDs on the most popular stocks, indices, for
And similar to an arterial line, you are going to have a systolic and a diastolic pressure with this. And the normals for that are going to be 20 to 30 over 10 to 20. And really, you can think about the pulmonary artery pressure as almost being like an A line for the right side of the heart. And if you do have an increase in your pulmonary artery pressure, it could be an indication of a few different things. The first one could be some sort of atrial or septal defect. You would also have an increase in patients with pulmonary hypertension. You would also see an increase if your patients were having left ventricular failure. And similarly to when you have an increase in your CVP when the right heart is failing, if the left heart is failing, you're again going to have that backup of fluid and volume and blood that is going to create more resistance, and the right heart is going to have to beat stronger in order to eject blood against that pressure. And finally, you may have an increased pulmonary artery pressure if your patient has either mitral stenosis or regurgitation. And now with this, you have either an incompetent valve to where blood is filling backwards out of the left ventricle and going back into the pulmonary vein, or in the case of mitral stenosis, enough blood is just not able to pass through that valve and causing that backup as well. All right, so moving on to our pulmonary capillary wedge pressure. This pressure is an intermittent pressure that we are able to achieve by inflating a small balloon that sits at the end of the catheter. What this will do is this will occlude the pulmonary artery, with the tip that we use to monitor pressure being distally to the balloon. This will prevent any flow coming from the right side of the heart and will give us an indirect measurement of preload on the left side of the heart. So if you think of a CVP for the left side of the heart, that is what the pulmonary capillary wedge pressure is going to be. Once you inflate the balloon, you're going to see a pressure that looks very similar to a CVP, with the waveform looking like this. The values are going to be a little bit different, and your normal range on this is going to be 8 to 12, and again, that's millimeters of mercury. And based on what your wedge pressure is, you can either be in a state where you have a normal pressure, an elevated pressure, or a decreased wedge pressure. If it's elevated, this could be things like fluid overload, could be aortic stenosis or aortic regurgitation, could be mitral stenosis, left ventricular failure, could be cardiac tamponade, or constrictive pericarditis. Cases where you might find a low wedge pressure would be hypovolemia or vasodilation.
After 30 days, I could not believe my before and after picture. I literally rolled back the hands of time 10 years. When I first saw this product, I thought...
Now, not all facilities nor all physicians will want you to get a pulmonary capillary wedge pressure, but it is important to note that if you are getting wedge pressures, that you don't leave the balloon inflated. You need to inflate the balloon, get your numbers, and then deflate it. Because when the balloon